All right, good morning, everybody. We are recording. It's time to get started. Just a couple things. Remember, again, evaluations. I will try to send out either later this afternoon or tomorrow. Um, Basically, about every 2 day or every 3 day update on what the response rate is for you guys. Again, if you hit 80% participation in here as far as the class goes, and again, I don't see those surveys until well after the class is over. As long as you make an 80% on your final exam, I will give you a 10% bonus on that score to go in for your final grade. I value what I hope I've proven to you. I value what you say. So I want to know what I'm doing well, obviously, because I'm going to try to go up for promotion this year. Or at the end of this year, but I also need to know from you because I respect your opinion. What do I need to improve on, especially as we've got one more semester left in the summer? So I want to try to make any adjustments that we got in there. Also, if you want to take part in the alternative final exam offering, which will be next Friday from 10 until noon, please make sure that you fill out that Google form so that I can get everybody squared away. We will meet in here if you're deciding that you want to take that your final exam early, so that you don't have as much of a rush next week. Anything that we need to talk about, chat about, or anything along that line before we start our lecture today? Yusuf. Okay, now correct, and I apologize for that. I'm in the process of working on that. The big thing to keep in mind here, as far as you should now you can see yourself in platinum how many IVs, how many youth you need, and how many adults, how many chest pains. You can see that, right? Okay. So again, as you're going through there, as far as when we're moving through, and I will try my best to get that document set up for you today. Everybody has to have 100% of all their ages, okay, across the board. We cannot simulate pediatric patients, so you got to have actual pediatric contact. So again, I'll come right to you, even if it is a BLS call in the summer, right now you can count anything that you've got. But even if you run a call and it's a BLS call and it's a 6-year-old or a 7-year-old or whatever age group it is, make sure you log that, okay? You got to have 100% across on all your complaints: chest pain, abdominal pain, syncopal episodes. Those are the areas where we have some leeway, where we can do some simulation on that over the course of the summer. So that kind of area I'm not nearly as concerned about. Also, you'll have to pass EMC 362 with a score of 80% or higher. My goal with 362 is to, number one, Tom, help you guys make sure that you meet all your competencies. And number two, we're going to do lots and lots of testing by unit. So there'll be a trauma test, there'll be a med emergency test, and so on. And you'll get 2 attempts at those exams. The exams will be the exact same exams, and you will take them, and I will give you some feedback after your first exam on these are the areas in which you are weak in. I will not give you wrong and right answers because, again, I don't want you just to memorize the questions. The reason I do that is I only want, Joe, when you go to take your registry exam, to pay for it one time and to take it one time because you've passed it. Okay, so we're going to do lots and lots of review. We're going to do lots and lots of testing. Got some folks that are coming in. We've got a ventilator course. We've got PALS. Got a guy coming in from University of Louisville who is going to do a presentation on large vessel occlusion strokes, which I'm pretty excited about. And then we've got Will Scott Smith that's going to come in and talk to y'all about pre-hospital blood administration. So we got some cool stuff that's going to be happening. Vacations. Please take a vacation, okay? I know you're getting a vacation paid for by the federal government, aren't you? Yeah, all right. Kind of, sort of. Anyway, I want you to take a vacation. I'm taking a vacation. My wife and I are going to Alaska for a week. So I want you to take a vacation. And that, if you when you take a vacation, I will work with you to make sure that you get caught up. Okay. Please don't schedule ride time or working a regular EMS shift on Tuesdays. All right. Because that's your class day. So try to schedule those outside. If you're taking a vacation, just let me know. Just let me know so I can be prepared and I can make some adjustments. I know Bella's got a vacation. I know Yusef's got a vacation. And so I'm hoping everybody else will take a vacation as well. All right. So that's kind of the gist of it. But you're exactly right. I will get that. I'll get that document uploaded so that you'll be able to refer to it. Yusef. Did you forget it? You're way too young for that. That head injury from the ambulance, huh? Okay. Anybody else? All right. So let's talk about septic shock. All right. So in septic shock, basically from a pathophysiological perspective, regardless of the come back to you.
Yeah. So the like age group contacts, that's just counting competencies. We don't have to have formative filled on the line.
So that you don't have to have what?
Formative competency.
I'm still struggling with this whole formative and because everything that you put in should be counting. So here's the thing I'm going to tell you. As long as you document it, I'm going to figure out a way to give you credit for it. I'm not going to make things up. But literally, if I have to go back through and review every one of each of y'all's labs, your clinicals, and your field time, regardless of whether you're doing an IV in the lab or you're actually starting an IV in the hospital or in the field, that should be going towards what your minimums are. And again, I will figure out. Again, I've got a meeting with the folks at Platinum to update me on how to do that next week. So here's the thing I would tell you from here on out. Put everything in that you do as far as like skills in as summative, because I'm almost 100% sure that the summative is pulling out and that's what's populating your reports. Okay. So again, I will have an updated report for you prior to the start of 362 so that everybody will have an accurate idea of where they're at. Does that help, Yusuf? Everybody got that? So from here on out, just put everything in as summative. IVs, meds, skills, innovations, and all that stuff. Okay? Anything else? All right, it's okay. So again, from a pathophysiological perspective, regardless of the age of the patient, what we're looking at here is an overwhelming infection within the body that results in the immune system being unable to fight off whatever the pathogen is that's coming in. As a result of this, what we're looking at is that we see very similar in some regards to what we would see in anaphylaxis. Massive vasodilation and vascular permeability. So we begin to have a vasodilation, which is going to drop our patient's blood pressure. So it's going to reduce particularly cerebral perfusion, but perfusion to all the rest of the body as well. And then secondly, the plasma begins to leak out, which lowers the pressure even further. Now, any person that is septic, and it's important that we understand the difference between having an infection and being in septic shock. In septic shock, literally, you see signs and symptoms of shock. Now, again, remember, even within septic shock, and I hope that I've beat this into your brains from trauma of those three categories of progression from compensated, decompensated, and irreversible shock. You have the exact same thing that happens regardless of the type of shock, and even in septic shock as well. So as we're looking at this and we're assessing our patient, you want to make sure when you're looking at your patient and they've got that high fever, but they're beginning to have that increased heart rate, much like we talked about, is the anxiety from hemorrhagic shock, is that, or after a trauma, not from hemorrhagic shock, but is that anxiety coming about as a result of just simply the normal action of the sympathetic nervous system? Or is it coming about because now we've got early decreased perfusion going to the brain? The exact same thing comes into play here when we're looking at septic shock. Do we see that heart rate up because the patient is in compensated shock, or is that heart rate up because, number one, they're fighting off an infection, and number two, they are having a fever? When our fever goes up, heart rate goes up as well. And that's the important thing to kind of keep in mind. So when we're looking at this, the symptoms we're looking for is that your patient is just going to look really, really sick. They're going to be lethargic. They're not going to have the energy to move around. And they literally may be very flaccid, especially pediatrics. Because remember, pediatrics compensate, decompensate, and then crash. Same way with old folks. Compensate, decompensate, crash. And so as a result of this, your patient may also have an altered mental status. Now, be aware, again, of what that whole spectrum of altered mental status means. It's not just an unresponsive patient. It's not just a patient that is simply speaking gibberish and not making sense of what they're saying. Look for those subtle signs and symptoms and use the caregivers, usually going to be the parents, but use the caregivers to help you to determine, is there a difference with this child as far as how they're acting. Patients in septic shock will have a fever early on. As the compensatory mechanisms begin to fail, your patient's body temp will now begin to fall. When it falls, they are truly in decompensated shock, bordering on irreversible shock. Again, in septic shock, think of body temp as one of your vital signs that you're going to be looking at. In septic shock, again, Tom, early on, the body's doing its best to fight off the pathogen. Fever is one way that we do that. We raise the body temp, and as a result, it tries to fight off bacteria, viruses that are in there. But if the body gets overwhelmed, now the bacteria, the viruses begin to win. And so it begins to overwhelm the body's ability to keep that body temp up because it's burning through ATP, and the body can no longer keep that up. And it begins to fall. Also, again, in that regard, keep your patient warm. Now, let me ask you a question. Okay, let's say that you've got a 6-year-old child. Mom tells you child has been sick for about a week, vomiting, diarrhea. They've been running a really high fever. When you do a temp on the patient, and your ambulances, if they don't, especially post-COVID, everybody's ambulance should have some type of thermometer. The best ones would be the electronic ones that they can scan either the forehead or the tympanic membrane scans. If that patient's running a fever, but blood pressure is low, heart rate is up, you're theorizing that we're probably in maybe compensated or early decompensated shock. Should you kick the heat up on in the back of your ambulance? And why or why not? Tom?
Say no, you gotta cool them.
Tell me why.
Because it'll help to like alleviate their symptoms. I mean, it'll lower their heart rate probably, which might increase their blood pressure.
Okay. All right. Anybody else? How nice of you to join us. It's okay. It's all right. Don't worry about it. Allie.
It'll help them like alleviate their compensation because since you don't want to make them hotter, But if you're cooling them down, when you have a fever, it makes your muscles leaky. So if you're starting to reverse that, it'll help increase your blood pressure and take less pressure off the heart.
So both of y'all are correct. We don't want to continue to keep our patients warmer than what they are, especially if their temperature is up in a fever range for the exact reasons both of y'all said. And so by trying to now here's the thing to remember. When we are trying to cool a person, don't bring them in the back of the ambulance and kick the air conditioning up on the back. What you're going to do is you're going to drop that temperature too quick. And what happens to us on just a regular, normal basis when we drop our body temperature too quick? What mechanical process takes over? Shivering, yeah. And the whole purpose of shivering in the body is to generate heat. Think of shivering as kind of like micro seizures, okay? And so, especially if we have an extended period of time of these patients that are shivering, John, now we've got lots and lots of body movement, muscular movement, and the whole purpose of that shivering is to generate heat. So take a passive approach to this. You might want the temperature to be a comfortable temperature in the back of the truck, and then begin to unclothe your patients, to take some of their clothing off. Maybe not all of it, but some of it, especially if it's wet. If they're drenched in sweat, in urine, we want to get that away because that's not comfortable for them, and it's definitely going to lead into the potential for hypothermia to have any type of wet clothing against their skin. So again, that's the thing that we're looking at. Kira.
I have two questions.
Yes.
So the first one is, what are some common illnesses or injuries that might cause a pediatric patient to have a septic shock? And the second one is, what if you've got a PADS patient who is too young to be able to shiver? Like they can't shiver.
Oh my. Okay. All right. So first of all, let's take your last question. The question about what if you got a patient that's too young to shiver, or I would add to that, in certain stages, late stages of hypothermia, our ability to shiver goes away. And this is true for adults and kids. It will happen much quicker with kids, and especially the younger age of kids. So if you have a child that is in a hypothermic state and they are not shivering, then we have to reverse everything that I just said about passive cooling, and we got to get active rewarming for them. So kick the heat up, get their wet clothing off, bundle them up in blankets. If we're dealing with like school-aged children or older, you can consider, keyword there, consider the use of hot packs under the arms, in the groin, and behind the neck, but never, regardless of the age of your patient, never put a hot pack directly against the skin. Always wrap it up in a towel thickness or more, okay, because you run that risk, all right? So, and especially if we're dealing with a very young, let's say we're dealing with a baby. Again, babies don't have that ability to shiver for probably the first 3 to 6 months. So we got to be really aggressive to come in there into play. Now, repeat your first question for me about etiologies or what causes sepsis.
Yeah, injuries or illnesses that are common.
So generally, we don't see injuries that would cause sepsis today. Most of the time, as far as any type of an injury that would come about, would be an injury, trauma, a puncture in the skin that would result in a child getting an infection and moving on. The nice thing about today is we have a really, really high prevalence of antibiotics, and that comes into play. Now, so for example, and I think I mentioned it in here, maybe it was in my 303 class. certain EMS agencies, such as Georgetown Scott County, right now, they're beginning to give, and I don't think they're doing it for peds, but they're definitely doing it for adults. They're giving prophylactic antibiotics for any type of a fracture that breaks the skin. Again, that's an awesome idea, because when you have a fracture that breaks the skin, now remember, skin is the largest organ you've got. It's one of the purposes of it is to serve as a barrier against bacteria, against viruses, and you get a break. Now that barrier is broken. So if they're prophylactically giving antibiotics, that helps to minimize the possibility that we're going to get an infection within the bone. Orthopedic infections are difficult and expensive and uncomfortable to the patient to try to clear up. It will literally take months to try to clear up a bone infection. So that would be care probably from a trauma. As far as any other type of pathogen, the most common that we see with kids, respiratory. Okay, respiratory. And especially we see this in early or late fall and early winter, especially when we begin to now migrate indoors. It's an urban legend that says, you know, you go outside in the cold and you're going to develop some type of a respiratory problem. That's not true. Actually, the reverse is true, in the fact that cold forces us to spend more time indoors. And again, kids, as I've shared with you, are bacterial factories, and they have a great transport system of sharing it between one and another, going from toys to doorknobs to whatever. And so that's where you see the increase of sharing, especially these respiratory problems. So for young children, for sepsis, it's primarily going to be respiratory. What do you think it would be for adult patients moving into geriatrics? What would be the normal? Allie?
For geriatrics, bed sores.
Say it again.
Bed sores.
For beds, now remember, I'm a geriatric, but I'm not confined to bed yet. So bed sores would definitely be one if they are confined to bed. This is why it's critically important in nursing homes to move your patients so that we don't develop those. This is another critical reason why, if you have an older patient and you got them on a backboard, pad that backboard before you put them on it, because within about 2 hours, there are certain patients, especially patients that are really, really heavy or really, really thin, that can begin to develop those bed sores from just lying directly onto a backboard. But what else, Yusuf? Leading into specifically what kind of disease? I'm talking about specific, definitely your depressed immune system. Pneumonia is one. It's not the most common, but the most common is UTIs, urinary tract infections, especially if you got patients that are in the nursing homes. One of the things that always amazed me when I was working a truck full time was to go in a nursing home again over the course of the year, and invariably, number one, heat was always kicked up high, even in July. And I worked in Georgia, and I mean, it gets hot down there. And then number two, I was always amazed to go in and look at the different colors in their urinary catheter bags, because you could see the rainbow of different colors coming as a result of, number one, infection, and number two, medication treatment. Yusuf.
So I was initially thinking that, but kind of touched on it. You normally see those in geriatrics that we have.
Very much so. Again, because remember, the cath does indeed provide irritation and the possibility for bacteria to begin to grow in that area. All right. So again, with fever, we're looking at here vomiting and diarrhea, especially. We are very concerned about the fact that, number one, remember, Sepsis brings about vasodilation, and then if we're losing plasma through vascular permeability, and now we're losing it because the patient is no longer able to keep fluid in because they're having vomiting or diarrhea. And most of the time, if your patient is vomiting, what are they not going to be doing? They're not going to be drinking much of anything at all because they recognize that. So this would be definitely an area of where you're going to need to jump in there with fluid resuscitation for your patient. Towards the end of that whole process, now we begin to see either cyanosis, but most of the time cyanosis will not be visible in your patient, but rather more of a pale or mottled skin that would come into play because of circulatory collapse. Any questions on sepsis? The big thing that we're going to do as far as treatment for sepsis, maintain body temp if they're hypothermic, fluid replacement. Okay, and then the regular treatment that we approach for any type of medically induced shock that we would see. Any questions? Burns. Okay. As far as we're going to talk a little bit about some abuse in this regard, and I think I may have gotten this slide out of order, so we're probably going to come back to it here in just a little bit. But what I want to do is talk about the different types of abuse that we would see within children. One of the most common types of abuse that we're going to see is going to be that of sexual abuse. Now, here's the thing to keep in mind. You are a mandated reporter, John. So what you're reporting are your suspicions. You're not an investigator. You don't have the background to investigate. But again, the nice thing about EMS is that we are invited into people's homes. And law enforcement would not be, the hospital would not be. But Catherine, you as a paramedic can come into the home and literally you're the eyes and the ears of advocating for these children if you suspect that they are being abused or neglected. Now remember, neglect can be abuse, or neglect may just come about as a result of the fact that the family just doesn't have enough money to pay for food, to pay for adequate housing. So in this situation, if you're seeing neglect, you definitely are probably going to want to follow up with that to see if maybe, Tom, that you have some connections either through social agencies, through churches, through non-governmental organizations that would be able to help to provide funding for this family to get better heating, better cooling, better housing, or food that they may need. But in the regard for abuse, and especially with sexual abuse, it ranges the whole gamut from someone having actual penetration of the child to something as just simple as a person exposing themselves. The key thing to remember here is that abuse of any type can happen in any family, of any culture, and of any socioeconomic background. Don't look at the wealthy family with a big house and say, that could never happen there. It does. And don't look at the poor family with a home that is maybe not the best in the world and think, I bet something's going on there. Because it doesn't necessarily mean because of their social status that it increases or decreases. Females are about 4 times more likely to be abused than males. Males are more likely to be physically abused, spankings, burns, things along that line, than females will be. But females are a much, much higher risk of being sexually abused. Here's the other thing, is that the abuser within sexual abuse is almost always somebody that the child knows. A family friend, or a family member, and to kind of keep that in mind. So again, if you're dealing with a child and they have some type of genitalia type of injury, and it doesn't match up with the story that either the child is telling or that the caregiver is telling, you got to report that. You have to report that. So how do we report it? Basically, what you have to do is you got to report it to the hospital, and then you document who you reported it to. I take it a few steps further, and I tell my students, because this was my practice, is that I also report it to my supervisor, and I document that. And then the third thing I do is I get on a recorded line to dispatch. Okay, a recorded line to dispatch, and I report it that way. And then I record who I reported that to as far as the dispatcher goes. This is truly a law enforcement issue. The reason that I'm so OCD about this is that, again, what you guys see is going to be much more vivid and much more in detail than what law enforcement or the hospital would ever be able to see. They're only going to be able to see and talk to the child. In many situations, John, you're going to have the child, you're going to have the caregivers, and you're going to have the environment in which that child was in when you found them. Again, child abuse is a crime. And so if the abusers feel like that there's a possibility, Kira, of them being pointed out for this, they're going to try to clear up any type of evidence that's going to be there. You as the paramedic are going to have a front row seat to being able to see that evidence before it disappears. And so, again, literally, this is one of those things of where I would tell you, you need to pretty much write a dissertation in your patient narrative of the facts. Do not insert your opinion about this, because, Ahmad, if you do, a really good defense attorney will take that, and even though 95% of your report is factually based, you have that 5% in there that's your opinion. Many times they'll get that report completely thrown out as the evidence. Now, I'm not an attorney, and I don't play one on television, but I just know that for a fact because I've seen it happen in multiple other cases. So again, try to maintain your emotions. We all, for the most part, like kids, and we want to protect kids. We were either a kid once. My youngest daughter tells me I still haven't grown up, and I take that as a compliment. Or we have kids of our own, or we have siblings that we can identify with. So try to maintain your professionality, but again, protect the child as much as you possibly can. When we're looking at overall assessment of this patient, some of the things that we're looking for, kids that are under the age of 2 generally don't have fractures. Why is that? The bones are what? Yeah, the bones are bendy. They bounce, remember? They're very flexible, okay? And so it is highly unusual for kids under the age of 2 to have fractures unless there's been some tremendous force applied. Now, if you got a child that's involved in a car wreck, okay, that's different, all right? So now we've got a story that lines up with this, with the presentation. But if you've got a 1-year-old, you got an 8-month-old, and they say, well, they rolled off of the changing table, and they've got lower limb fractures. What's wrong with that story? Why would a child generally not have lower limb fractures if they're an 8-month-old and they, for whatever reason, the parent got distracted? It's possible. And they say that they rolled off of the changing table. Use it.
Why wouldn't you feel like they have the ability to fall like feet first? And if they're rolling, their head typically typically goes down first.
Okay. Allie?
I was gonna say scrunch.
Now, what do you mean by scrunch?
Like they fold their legs and their arms in and scrunch and walk.
Okay. You're a person that has been around babies and kids. So, yeah, you're exactly right. So, they do have a tendency to bring those up. Yusuf, you're also on the right track in there in the fact that, remember, babies have got a great big head, okay? Gravity comes into play here. If a child is going to begin to roll, that head's going to come off, and it's going to go first. So now, if a parent says the child rolled off and they've got a head injury, that might be plausible, okay? But again, if they roll off and they say, well, they fractured both of their lower legs and it's a carpeted surface, I'm not buying it. Not buying it. Again, in that situation, don't dispute with the parent because your goal at that point in time is, number one, to provide care and, yes, pain management for even a young child. But number two, and it's just as important, is you got to get that child out of that scenario, out of that environment, and get them to a safe location, so that the abuse can't happen in the short term. If it actually is happening, and an investigation can come about. Again, you have to report your suspicions. The other thing that we look at here is that if we see bruising that happens or injuries in multiple stages, or if we see bruises all over the body. Now, there are some bruises that are going to be normal depending upon the age of the child. If you got a child that's somewhere between the ages of 2 and 4, seeing bruises on the forehead, seeing bruises on the knees, seeing bruises on the hands, perfectly normal. Why? They crawl. Good. What else? John?
Maybe learn how to walk and fall.
Yeah. Yeah. Again, walking, falling, okay? You're exactly right. They crawl. If you ever watch a toddler, your son, right? How old is he? 20 months. You're getting ready to find out, okay? Once a child begins to learn that they've got mobility, that's a level of freedom for us. It's interesting as humans, especially as males. We have this, first of all, we can walk, and now we try to get away from our parents, and then we get our bicycles, and we try to get away from our parents, and then we get, about 16, 17, 18, we get a car, and we get away from our parents. But you will see in this situation where when they begin to move, okay, again, they still have a large head, poor neck muscle development, and toddlers lead with their head wherever they're going. So having bruising on the front of the forehead is normal. Bruising over bony areas in that age group, probably just a normal part of growing up. Bruising on the back or the buttocks, not so much. Not so much that we're going to see. Yusuf.
Now, when you talk like bruising on the buttocks, like my son just likes to pop down, and he's had a few bruises on his butt. Obviously, I'm not beating them, but they're not like diffuse like bruising.
So the big difference with that type of bruising is that I'm glad you brought that up. Number one, right up there at the top, patterns. So bruising on the bottom will, if it's been inflicted by abuse, will often come about as a result of the hand or a belt or a cord. So you will see definite patterns in that regard. What your son is probably experiencing as he's beginning to learn to walk and he plops down on his bottom is that you kind of see this splotch, this just an overall type of bruise that has irregular margins or irregular edges to it. Again, that's just a normal part of them learning to walk and move along that way. And so in that situation, what you're looking for would be, again, on the bottom, the back, or even on the face. Generally, bruising right around here is highly unusual, and that's probably going to come about because a child has been slapped or hit. Does that help? Does that kind of
So we're looking for like straight edges and
very defined patterns? Okay, very defined patterns in here. Again, um, if you've got somebody, there's a big difference between a swat on the bottom and abuse. If the swat on the bottom is strong enough that it leaves the outline of a hand, that's not discipline, that is abuse. The same way if you've got like a belt mark that you have a defined pattern, or an electrical cord, or even like sometimes I've seen patients, pediatric patients that have been beaten with clothes hangers, and you'll see those very defined patterns. But again, just kind of plopping down and having irregular bruising, especially on both sides, because generally when a child falls, both cheeks make contact. That's where you're going to see the difference. Does that help? Awesome. Okay. Increased intracranial pressure in a child. Now remember, with a very young child, you can see that increased intracranial pressure as a result of fever. You can see it as a result of crying, especially when you're assessing the head, and if the fontanelles have not yet closed up. As you run your hand over the head, you can actually kind of feel a bulge in there. That's normal. But if you've got a child that's got a head injury, now what we have to do is we got to investigate even further. Again, even if a child has rolled off of a changing table, that's concerning because, again, the parent has to be the adult and pay close attention to the child and protect the child. If we're looking at intra-abdominal trauma in a small child, again, kids aren't mobile yet at like 1 year. At 18 months, are starting to get mobile, and generally they're not going to have any type of abdominal trauma that's going on unless it was purposely inflicted. Now, here's the key thing that you want to look at here is that you want to line the story up with the injuries that are given. Here's the other thing that you want to look at. If the caregiver has one of these types of characteristics, either they are overly concerned, they're concerned, and their anxiety and their questioning of you is over the top, or if they're simply not involved at all. If they're over here texting somebody while their child is being taken care of by you as a paramedic, that's not normal. A normal caregiver, regardless of whether it is the parent, the mom or the dad or the grandparents, are going to be very, very much focused in on that child. And they're going to watch you to make sure that you are providing the best care. But if they're not involved, or if their questioning of you is over the top, that's a key thing to take into consideration. Questions on abuse. Other specialized areas that we look at would be kids that have trach tubes. Now, it used to be back in the 60s and 70s that these kids would have been in an ICU, they would have been taken care of, and the cost would have been astronomical either for the family and or for society. You're going to be taking care of a lot of these kids at home, all right? And so some of the issues that you're going to come into play with would be dealing with these trach tubes. And these are different types of trach tubes that you can see here on this particular graphic. Basically, we've got this one that comes into play, and they're all pretty much the same way. With this, what you're looking at is you have an inner tube, and then the inner cannula, and then you have this outer area here that basically provides some structure and restraint to hold things in play. The most common problems that you're going to have if you've got a child that has a trach tube is going to be plugging. What you're going to see is kids, again, we know that they especially when they're getting sick, they produce lots and lots of mucus, and so that mucus is going to come into play there and block that. One of the really good things that you will see here is that the parents are, for the most part, are the experts in the management of their children if they've got a trach tube or if they are on a ventilator. So if you have been called because the child's having a problem with their tube, something major is going on as far as what's coming into play here. And these are some of the things that you can see, especially early on. Many times you can see some additional bleeding that begins to form around the tube because it's new, it irritates the tissue, and now we get a bit of bleeding that comes down into the trachea that maybe the parent is not able to get out. As far as what you need to do, all of your care priorities are going to be the exact same thing. Number one, you got to keep that airway open, which means you need to suction it. Now, again, remember, when we're suctioning into a trach tube, that is a sterile procedure. Your ambulance should have sterile suction equipment on board, including sterile gloves. Worst case scenario, let's say that for whatever reason you're running back-to-back calls or for whatever reason you find that you don't have the sterile materials, go with the cleanest you have. But that's a potential problem for malpractice for you just simply because your truck should have these pieces of equipment on there. Keep in mind that when you suction a patient, regardless of the age, a couple things you got to remember when you're taking the suction, especially if you're going into a trach tube, in addition to the mucus that you're trying to get out, what else are you taking out? You're also taking air / oxygen out. So you want to watch your suctioning time. Now, it used to be we would say you never suction for more than 10 to 15 seconds. That is gone. Okay, because what if your patient is producing copious amounts of mucus or fluid within their airway that goes longer than 10 to 15 seconds? So the key here that I'm going to tell you is that there is no hard and fast rule anymore. You want to get that airway suctioned out as quickly as you can so that the ventilatory process can come into play. Again, remember, you're causing hypoxia, John, when you're suctioning your patient. So you want to watch them really, really closely. What is the second problem with suctioning a patient, especially when we're suctioning into a trach tube?
You can vagal them down.
Oh, man, I love this class. Yeah. So you got to watch, especially pediatric patients, because they will vagal down really, really quickly, okay? And so the last thing we want with pediatrics is a hypoxic with a bradycardic rate, because there's a good possibility, especially if they're sick, and in many situations you're going to have some type of an infection that's going on. Especially in that situation, now you're going to make a bad situation even worse. Don't be afraid to ventilate between suctioning episodes. And again, I don't have a hard and fast rule to give you of saying suction for this many seconds and then ventilate. What I would tell you to do is to watch your patient. Now, again, you can watch your SpO2, but what's your limitation of SpO2 as far as when you're suctioning your patient?
It's not going to show what's going on right now.
Yes, ma'am, you are correct. So it's not going to give you an indicator of what's happening right now. It's going to give you an indicator of what happened 3 to 5 minutes ago, okay? So you can have a perfectly normal SpO2 and your patient is hypoxic. So again, watch your patient, assess your patient. If in the worst case scenario, you got to blow some of that down into the lungs, that's the lesser of two evils, okay? But only you can decide that as far as what you're going to do. When you're suctioning your patient, let them, if they're able to, sit up in or lie in whatever is comfortable for them. The other thing is, if you've got to transport your patient and you've got a failure of a ventilator, again, just take your BVM connect it up to the tube and begin ventilating your patient. I remember a number of years ago, again, I spent a huge chunk of my career down in Georgia, and we would periodically have to go get a 16-year-old young man and take him to the hospital who was on a ventilator at home. He was awake, alert, but he just had some ventilation issues that he wasn't able to breathe on his own. And in taking his mom was the expert. When I walked in, it was kind of like, okay, ma'am, you tell me what I need to do here, because she dealt with her child 24 hours a day, 7 days a week. And so again, park the ego at the door, because again, that parent, and to be quite honest, most of the time it's going to be a mom. In my experience, it's going to be a mom. That parent is the expert. They know more about that ventilator. They know more about their child than you do. So again, that gets the parent on your side, and it raises their level of confidence in you as well. But invariably, what we would have to do, because the house was small, when we would take them out, we would take him off the ventilator. We'd have to unplug the ventilator. At this point in time, there were no battery-powered ventilators. And the kid would bag himself, which the first time that I did that, it was kind of like, this is kind of creepy and weird looking and cool all at the same time. You know, we would roll him out, and I would be at the foot of the stretcher pulling him out. And it's kind of like, this kid's just laying there doing this, looking around. And so, again, adjust your care and treatment for your patient as to whatever that they're going to need. Apnea monitors. Babies that are born who have a tendency to stop breathing are at a much higher risk for sudden infant death syndrome. So to minimize that, what they do is that they will connect the child up to an apnea monitor when they put the child down to sleep. Generally, what these do is that they measure and they monitor the physical movement of the chest, as well as today, some of them will actually monitor the passage of basically their end-tidal CO2 monitor. So when that stops, it will send out an alert. In the past, the monitor itself would just send out a piercing alarm, but today, with the way that we are, it'll send an alert to the parents or whoever else they want to their cell phones to alert them so that they can go in there and get them. If the alarm goes off, you will be called. Most of the time, one of two things will happen. Number one, you get there, the baby is fine. They're looking around, they're kind of startled because there's a stranger in their house and there's nothing that's going on. Follow the lead of the parents. If you've done your assessment, and again, don't be so busy with calls back up and waiting that you don't do an adequate assessment on the patient that's in front of you. But to do an assessment on that patient, look at them closely. If they're okay and the parents are requesting not to go to the hospital, then you're okay, because the apnea monitor has done its work. That's one. The other situation is going to be a baby that's in respiratory arrest. And so in that situation, you're going to fall back and you're going to do a full resuscitation. Those are the things that you're going to be looking at. We're looking at some specialized situations here, and one of the ones is going to be shunts. Basically what happens here is that cerebral spinal fluid begins to build up in the head, and it is not able to be delivered throughout the body and ultimately into the GI tract like it normally would, which means the pressure begins to develop on the brain. In this, when these shunts fail, most of the time it will come in as an altered mental status. So the child will often go from being okay to being unresponsive in a matter of just maybe 10 to 15 to 20 minutes of going on. In doing your assessment of that, there's nothing that we're going to be able to do here, okay? Nothing we're going to be able to do as far as relieving this or getting the shunt to working, but what you would do is that you would just simply fall back on, this is an ALS call, and we're going to maintain our respirations, we're going to ventilate our patient, we're going to provide cardiac support, but understand The whole concept here is increased intracranial pressure. All right. And so be aware of that. With your head injury patients, what is one thing that you should be doing for all of them, regardless of their age? Why entitled? You're right. Tell me why.
With head injuries, you want to like ventilate keep yourself 130 to 35 to help reduce that CP.
Excellent. So let entitle direct your tidal volume and your rate of ventilation. And Yusef is exactly right. You want your entitle to be between 35 and 45. I would take it one step further and say that you want it to be on the acidotic side of that number range. Okay? Excellent. Any questions on shunts? Anaphylaxis. Kids can be allergic to just about anything. And in particular, we're seeing an increase in kids that are allergic to things such as peanuts, shellfish, and other foods that come into play here. When we're looking at a child that has an anaphylactic reaction, the big issue that we want to address within here is we've got to maintain our airway, but we got to get epinephrine on board. Now, somebody do a real rapid pharmacology lesson for me and tell me why is epinephrine so important for these particular patients? What does it do?
Vasoconstriction.
It's a vasoconstriction. Good. Why is that important in anaphylaxis?
Because their vessels are all dilated and leaky.
Dilated and leaky. So epinephrine takes care of that, causes constriction, causes the leakiness to go away. What else does epi do? Tom?
Bronchodilation.
It's a bronchodilation. So we see three things with anaphylaxis: vasodilation, leakiness of plasma, and bronchoconstriction. We got to get that open. Remember, the speed of onset of an anaphylactic reaction will often give you an indicator of how severe it's going to be. So if it is a slow onset, you may only have to give them some Benadryl, and you don't have to go with epinephrine. Remember, in your protocols, you're not required to go epi, Benadryl, steroid, whatever it is that you're looking at giving. If you're going to give a long-term steroid, but if it is a mild reaction, giving them Benadryl would be perfectly acceptable. Also remember, epi, short acting. Benadryl, much longer acting. Takes longer for an onset to come into play, but it's going to act much, much longer. Seizures are common in kids. Okay? The most common seizure that you're going to see, febrile seizure. Most of the time, the seizure will be over by the time you get there. In that situation, the care that we're going to give is primarily going to be supportive, or number two, remember, febrile seizures are brought about by a sudden spike in a fever. If the fever is still there, now we got a decision to make, John. Do we want a cooler patient or do we not? Now, here's the thing to remember about febrile seizures. It's not how high the fever is. Kids can have a temp of 102, 103, even 104, and they'll give them some Tylenol and send them home. You or I, we have a fever of 104, we're going to the hospital, and we're going to be admitted. And a good possibility we may go into ICU, because with a temp of 104, we're probably septic. Okay? So the big thing that we're looking at with kids here as far as the febrile seizure is how fast it goes from normal up to whatever its peak is. The faster it happens, the more the possibility of bringing about increased intracranial pressure, and that's what results in our seizure. So as we're looking at this, the key thing to remember are the causes of seizure as well as the results. Hypoxia can cause a seizure. You got a toddler that's been roaming around on the floor. They get something in their mouth. Now they got an occluded airway that can bring onto a seizure. The other thing to remember is during a seizure, your patient does not breathe. Okay? It does not breathe. That's why, especially with children who have a new onset of epilepsy, we are concerned about status epilepticus. Status epilepticus is defined as a patient that has more than one seizure without an intervening period of waking up. So your patient seizes, they go into this postictal state, and then they seize again. Our big concern is the more they seize, the lower their oxygen content is going to be, and as a result, now we're going to run into big issues as far as hypoxia going to the brain. With all kids of let me back up. With all people of seizures, we want to stop that. We want to check a blood sugar because many times a lowered blood sugar is going to be what that precipitating cause is going to be. Not always. Your child may have a history of epilepsy. So once we've ruled out the seizure, and remember, for kids that are younger than like 2 years of age, when you do a glucose check, get the blood from their heel, not from their finger, because they don't have a lot of perfusion to their fingers, and so you're just causing some pain and fear if they're awake. But get the blood from their heel. I have much more vasculature in there, and you get a better draw. In the seizures, don't be afraid to give a benzo. Okay, we can give lorazepam or diazepam, whichever one that you have on your truck. And again, in your pediatric situations, I'm not going to ask you to memorize these drug dosages for very infrequent medications. I would much rather you look those up. But again, don't be afraid to give it. We can give it IV. We can give it IM, but let's be honest, in a pediatric patient, it's not going to work fast enough. So our best ways are, number one, is to give it IV. If we can't get that started, then we can go with an IO. If in the extremely rare situation, now that we're able to establish IOs, you can't give it through an IO, you can give it rectally. The way that you do that is you have take your syringe, break the needle off, and put an IV catheter on it. A 16 gauge is ideal. Lube that with some KY jelly, insert it into the rectum, give it just as slow as you would if you were giving it IV or IO. The vasculature within the GI tract will pick that up really, really quickly, almost as fast as if you were giving it IV, and that will work as well. Again, we don't see much rectal diazepam given anymore, at least by medical professionals. Parents will give it all the time if their child has a history of seizures. They'll give it all the time. But so that will be probably the situation where you would see that most commonly. Hyperglycemia. What is the big concern that we have with hyperglycemia for our patient? Anybody? Tom? Dehydration. Okay. Blood sugar goes up. Patient begins to vomit. They begin to urinate. Again, that urination continues until they are very, very dry. The fact that they're vomiting moves things out of the stomach. Here's the other thing that comes into play. What's going to happen to that patient's pH early on if they have, well, let me back up. Let's say that our patient is not a diabetic, but they've got long, protracted chronic vomiting. What's going to happen to the pH of our patient? They're going to be what? Actually, they're going to become more alkalotic. Remember, what they're vomiting are stomach contents. The contents of the stomach are primarily hydrochloric acid. And so if they're vomiting, and they're not taking anything else back in because of the vomiting, The acid is secreted in the stomach primarily from food that comes in. And so your patient can actually become alkalotic in that situation. Yes, sir.
even with the hyperglycemia.
Not with hyperglycemia. That's why I kind of changed it up a little bit, because now what we've got is we got diabetic ketoacidosis that comes into play there, that goes much, much quicker with this. The big thing that we're looking at here is, just like Tom said, fluid replacement. Now, if you're working in a hospital, you're probably going to start an insulin drip on these folks. We're not going to do that pre-hospital. But understand that the reason that they're giving insulin is for what? What does insulin do in the diabetic patient? Use it.
Allows glucose into the cells.
So it allows the glucose to move into the cells. Okay, it's almost kind of like being on the ocean in a raft and dying of thirst. You got all this water around you, but you can't use it because it's salt water. Similar situation with a hyperglycemic patient is that they've got all this glucose around them, but it can't get into the cell because insulin is not there to unlock the receptor. Remember, the receptor for glucose on the cell is really, really small. The glucose molecule is really, really big. And as a result, now what we got to do is we got to have insulin to bring that in. We've talked about assessment of the abusive child. We've talked about special needs. Let's talk a little bit more as we close out about abuse, okay? And again, I put this slide in here to understand these next slides. If you're not comfortable looking at them, just look away. I don't have a whole lot of them on here. In this situation, this kind of comes back to what we were saying, Yusuf, a while ago with your child plumping down and having normal growth type of bruisings. Basically, what we're seeing in this situation is that this child was beaten with an electric wire, and down on here, you can see these defined patterns that we see in this regard. The injuries and the wounds that we would see up in here are in no way, shape, or form any type of abuse. The thing that we also see in here would be with this patient, especially if this child were to be dipped into boiling hot water, is that look for burns on the lower extremities that are circumferential. Kids, as they get older and they begin exploring, and this is one of the reasons why, if you've got kids, make sure you turn the pot handles in towards the center of your stove. They'll reach up, they'll pull down the pot handle, and if you're like making spaghetti, heating water up or whatever, that water splashes down on them, scalds them, second-degree burns, very irregular type of pattern. In some situations, parents will take heat water up and they will just simply begin to put their child into the water. You'll see circumferential burns around all of the lower legs that are about at the same level, and they have a definite pattern. Again, when you see definite patterns to injuries, something is going on there. Why I got my slides out of order, I do not know. We've talked about the specific parts of abuse as far as what we've got in there. We talked about perpetrators of abuse. Can be anybody. Generally, what we're looking at here is that the indicators generally are going to be from people who have chronically ill children, have a higher risk just simply because they get pushed to their limits, they're tired, they don't sleep, and they make a bad decision that may affect their child. The other thing that we see here quite common, yay, we're probably number one or number two in this regard in Kentucky, is that if mom has a child and it is left in the care of a male who is not the child's parent. Okay, so it could be what's called mom's paramour, basically a boyfriend that is there. He resents the fact that he's having to take care of this child. It's not his child. He's having to expend money on this. And now that raises the level that that person is going to come into play there. Again, when we're looking at this, abuse is a crime that is passed on. Many children or many adults who go on to abuse children were abused themselves. That is not in any way, shape, or form an excuse. Okay, it's just a fact. Okay, so kind of keep that in mind. When we're looking at pediatric, and I apologize, I'm not sure. I must have been on drugs the day that I made this presentation because it's all over the place. The big thing with pediatric fluid management is get an IO started. You do not have to have a failed IV attempt in order to start an IO. If you look at the child and you go, I don't think, number one, this child can live with an IV, and number two, I don't think I'm going to be able to get an IV, then go directly with an IO. Same principles apply. Listen to your breath sounds. Try not to put them into overload. You can give them ringers if they are in hemorrhagic shock, if they are in dehydration state. Normal saline will be okay. Ringers is actually better. We're going to give them 2 boluses regardless. You give them a bolus, they get better. We're going to give them a second one. Why is that? And this is true for all patients. Yeah, it's called third spacing. So basically, you have about a third of the space of the fluid will, within the next 1 to 2 hours, migrate outside of the vasculature, and now they're coming back. So what we want to do is we give them a fluid bolus, and we're going to give them another fluid bolus. We're going to watch that really, really quickly. The bottom line here, as far as pain management goes, is we feel comfortable giving adults pain management, but sometimes we don't feel comfortable giving kids. Understand that kids cannot communicate with you as well as can adults, but watch for your children. Look at the mechanism of injury that they've got on. Look at the severity of the injuries and understand that they're probably having the same types of pain that an adult would be having for that.